Now we're going to see multiple sclerosis. Multiple sclerosis is an autoimmune disease in which the lymphocyte, this CD4 positive lymphocyte, interact with macrophage, and they damage the myelin on the central nervous system, so they damage the oligodendrocytes. So here we will have acute plaques and chronic plaques. The acute ones would be this interaction, and here the conduction is blocked, so the patient has the symptoms. Here in the chronic plaques there is remyelinization of the plaques, and so the patient is recovering from that symptoms. The clinical presentation could be just progressive, secondary or primary progressive, relapsing, remitting, etc. The most common type is when the patient has times free of symptoms, but they do not resolve completely. And this is the most common form. The other one would be just progressive, and there are no free intervals, and the disease is just getting worse and worse and worse and worse. The symptoms could be cerebellar involvement, so could have ataxia or dysarthria, dysmetria, tremor. Could be abnormalities on the sensitive system, numbness, or on the motor system. Could have paralysis of something, or can lose temporary division of something. This is very associated with optic neuritis. Also with transverse myelitis. Certainly we need to distinguish this between other two diseases like optic neuritis just alone, or infectious diseases that can produce a clinical symptom very similar to this. Alright, the diagnosis is with the MRI. On the MRI we would see this myelin damage by these plaques. We would do a MRI with the T2 and gadolinium. In the T2 image, for example, the lateral ventricles, the liquid looks white, and we would give gadolinium to enhance the lesion, the plaques, and we will see them. But we need to be careful because maybe the patient has gadolinium allergy. This would present if the patient has chronic kidney disease and gadolinium allergy. This would present as collagenous deposition of fibrous material on the kidneys, and would lead to the kidney damage and abnormalities on the renal function test, for example, creatinine, blood urea, nitrogen, etc. The treatment is for acute exacerbations. We would give steroids, or could be plasmapheresis or IV immunoglobulins or something like that. For 3 days orally the corticosteroids, and then we will taper on in 4 weeks, months, etc., something like that. For the spasticity that the patient can have, we would give baclofen. For fatigue and depression and pain, we can give tricyclic antidepressant drugs like fluoxetine. Fluoxetine is a selective serotonin reuptake inhibitor, but we can give amitriptyline, for example. What else? For urinary incontinence, we would give anticholinergic drugs. For other kinds of anticholinergic effects that the patient can have, we would give cholinergic medications. We can give glatiramere that blocks the potassium channels. We can give fingolimod. In fingolimod, we need to be very careful because this can lead to cardiotoxicity and other damage to the lungs or something like that because fibrous deposition. And the most important in multiple sclerosis is to treat them, and one of the treatments most commonly is natalizumab. Natalizumab is a monoclonal antibody against the integrin 4, but this can increase the risk of progressive multilevoencephalopathy, rapidly progressive multilevoencephalopathy, that is due to the John Cunningham virus, reactivation of this virus. So before giving this treatment, we will test for this, and before accomplishing 2 years after the treatment, we will check again.